Ready?
Okay, so we are all set now. Good morning, friends. Welcome back to Saturday Club morning meeting. And today we have Dr. Chirag Seth, a very well-known cardiologist who has been our guest speaker earlier also. To formally introduce him, he is interventional cardiologist practicing in Vadodara. He has more than 2 decades of experience. He basically had his initial training at SCPGI, Lucknow. And he got his DM in cardiology from King George Medical University, Lucknow. He also got training in electrophysiology from Escorts Heart Institute, New Delhi. And he has several publications to reputed index journals to his credit. And he has been invited as faculty at national and international academic events. So over to you, Dr. Chirag. He'll be talking about when heart needs to obey, an update on cardiac pacemakers. Over to you, Dr. Chirag.
Yeah. Good morning, everyone. Thank you, Dr. Satish Bhai, for this warm welcome and introduction. It's always a privilege to be there at this meeting, and it will be. I hope this talk is it adds to our understanding of how the devices work, and it should be helpful for our day-to-day treatment of the patients. So I'll share my screen.
Yes.
Yeah. So I'm sure everyone is able to see the slides. Okay, so over to the talk when the heart needs to obey. The focus is on the update on cardiac pacemakers. So let us start with a brief understanding of electrical system of the heart. We'll not go into a lot of technicalities, but let us keep it simple. So as we know, the impulse, cardiac impulse is generated in the sinoatrial node in the right atrium near the site where the superior vena cava joins the right atrium. From the sinoatrial node, the impulse travels via various internodal tracts towards the AV node and via interatrial pathways like Pacman's bundle to the left atrium. The impulse, after passing through the AV node, goes down the His bundle, and then the conduction system divides into left bundle and right bundle to give electrical activity and impulses to the respective ventricles. And beyond this left bundle and right bundle, impulses, smaller innervations, they go to the individual myocardial cells, and that's how the impulse travels throughout the heart. So after this brief introduction, let us go ahead. When does one need a pacemaker? The commonest indication of a pacemaker is a bradycardia, and bradycardia because of 2 dominant reasons. One is disorder of impulse formation, that is disorder localized at the sinoatrial node, and second is disorder of impulse conduction, and that is the conduction of impulse across the atrioventricular node and His bundle. Out of the 2, the commonest reason why patient needs a pacemaker is disorders of impulse conduction, that is atrioventricular node. And commonest cause is a degenerative complete heart block. That means impulses which are generated at the atria, they are unable to go via the AV node down to the ventricles. Almost 80% of the patients having a bradyarrhythmic disorder, they have problems with the AV node, and 20% of the patients have disorders which are localizable to the sinoatrial node. So let us just go through the example, what happens in a patient who needs a pacemaker. So this is, let us say, is a patient who has a recurrent giddiness. We can see from the surface ECG that the QRS complexes are bizarre, and they are little erratic as far as rhythm goes. And if we see carefully, The QRS complexes, let us say the first beat does not have a preceding P wave. Second beat also does not have preceding P wave. Third beat has a P wave. Fourth beat has a P wave. Again, fifth beat does not have a P wave. Sixth beat also does not have a P wave. The last two beats have preceding P waves. That means this patient has disorder of impulse generation, and this is localizable to the SA node. So when such patient presents with recurrent giddiness, we know that that patient has sinus arrest, and this patient has a sick sinus syndrome, and he may be a candidate of a pacemaker. Let us say this is one example of a Holter study of one of the patients. And what we can see here that you have QRS complexes in a 12 lead ECG, but you don't see any P wave preceding the QRS complex. That means there is a complete loss of sinus activity. The impulse is not generated from the sinus node. And what we are looking at is a junctional rhythm. And this is evident by a retrograde P wave. That means a P wave which is falling after the QRS. So it's a junctional rhythm going on and with a total lack of sinus activity. So this is again one of the examples of a sick sinus syndrome. This is one example of one of the patient who has an exertional syncope. So what do we see here? You can see it is clear to see here in the first set of ECG here that a P wave is followed by a QRS for the first two beats, but the third beat, a P wave is not followed by a QRS. Last two beats again show P wave followed by a QRS. That means there is sudden loss of AV conduction. And when we see this kind of ECG, it is a sign of a high-grade AV block. High-grade AV block means a Mobitz type 2 second-degree AV block. Why so? Because the AV node has a property of Wenckebach phenomena, meaning thereby, as the atrial rate goes up, gradually the AV conduction starts declining. But below the level of AV node, that is infrahesian region, in that area of the conduction system, the conduction follows principle of all or none, meaning thereby either the impulse will conduct or it will fail to conduct. There is not going to be any Wenckebach phenomena. So across the AV conduction, these two phenomena are most important. One is Wenckebaching, which is localized to the AV node, and second is below the level of AV node, where the impulse either conducts or fails to conduct. And therefore, whenever we see this kind of phenomena, it is a sign that the infrahesian conduction is badly affected. And this kind of proof almost always warrants a pacemaker. And this is a malignant form of high-grade AV block and almost always proceeds a complete heart block. You can see in the next set of ECG here that you can see a regular ventricular activity and lot of P waves, but not every P wave is followed by a QRS, and this is typical of a complete heart. So this is a patient who is having a complete heart block. So these two slides show the commonest indications of a permanent pacemaker device, that is a complete heart block. There can be other indicators where a pacemaker may be needed. Let us say a patient who has unprovoked syncope. Unprovoked means there are no reasons why a patient should suddenly faint. And when you see the ECG, either the patient has a left bundle branch block or a patient has a bifascicular block. So in the light of left bundle branch block or a bifascicular block, if a patient has a pacemaker, there is a high probability that a patient is likely to have a bradycardia as a cause of his syncope, and further monitoring with Holter may be warranted. And when symptomatic, yes, this kind of patients also will need a pacemaker. So in brief, these are the indications of pacemaker implantation. First is impaired sinoatrial nodal function, wherein the commonest indication will be a symptomatic sinus bradycardia. We call it when the awake heart rate is less than 40 per minute. One can have sinus pauses more than 2.5 seconds during awake hours. You can have sinus arrest with a junctional rhythm. And even bradycardia can be part of tachybrady syndrome, meaning thereby at certain point of time, patient has bradycardia. At other point of time, patient continues to have atrial arrhythmia in the form of atrial flutter or fibrillation. So both ultimately indicate that atrial scarring is significant, and therefore patient is having both set of disorders at different points of time. And lastly, there can be chronotropic incompetence, meaning thereby with exercise or activity, the heart rate fails to go up. So these are the indications of pacemaker in patients with impaired sinoatrial nodal function. And second set of disorder is impaired AV nodal conduction, as we have seen here in the previous ECGs, type 2 second degree AV block. bifascicular block with a prolonged PR interval, and a complete heart block. So most patients will have one of the indications listed here for getting a pacemaker implantation. So what are ultimately pacemakers? Pacemakers are implantable devices which provide electrical impulse to the heart. Impulse is generated by the device and it is transmitted via electrodes to activate the cardiac musculature. So what we need to understand is that the conduction system that is there in the heart, it has got a higher conduction velocity. So whenever impulse travels via conduction system, that is from SA node via internodal pathways to AV node down the conduction system, the conduction velocity is faster. Whereas impulse, when it passes through muscle, it is going to have a lower conduction velocity compared to the specific fibers. And what pacemaker does is it is providing electrical impulse directly to the cardiac musculature. And therefore, the conduction passing via the musculature is likely to be little slower than what is passing across the normal conduction system. So pacing needs a voltage applied between 2 points and commonly between the cathedral tip and annular ring of the electrode. Once implanted, what a pacemaker does. So whenever a device is implanted, pacemaker has several set of functions. If we try to understand in a very simple terms, it senses native cardiac activity in whichever chamber the lead goes. If the lead is in atrium or ventricle, it senses native cardiac activity. Second is it paces if it does not sense a native event. Let us say if the lead is in atrium and if it does not sense atrial activity, it will give an impulse to atrium, and that is called a lower rate. The same thing happens for the ventricle also. If it does not sense a native ventricular event, then it will give an impulse to the ventricle at a lower rate. That lower rate is usually programmed by us, typically between 68 and 70 beats per minute. So if it senses native cardiac activity, it remains silent, but it remains vigilant of every electrical event generated. Meaning thereby, if you have a program at the rate of, let us say, 70 beats per minute, if it does not get next impulse at a stipulated rate, it will keep on giving another impulse. It tracks every atrial activity and then paces the ventricle at a programmed AV delay. And this is how it reduplicates how a natural heart functions. And with this sensing of the event, it tracks 1:1 atrial event up to a maximum upper rate of 120 to 130 beats per minute. So a person who is having a pacemaker implanted can have his own heart, heart rate varying between a 60 to 130 beats per minute, which is reasonable for a day-to-day routine activity. And there are rate responsive pacemakers which can sense patient's electrical activity and allow heart rate escalation to happen based on the sensors which are already there in the device. So going to the types of pacemaker, what are the types? So according to duration of the need of pacing function, if we have a temporary need, let us say during post-operative phase or during acute myocardial infarction or acute hemodynamic insufficiency, the patient has bradycardia. If it is happening as a part of acute ST elevation and myocardial infarction, let us say inferior wall MI or anterior wall myocardial infarction, all those patients may need temporary pacing. Like once you revascularize, majority of patients may not need a permanent device. Another common example is electrolyte imbalance like hyperkalemia. When you have atrial standstill and one can have bradyarrhythmia as a part of electrolyte imbalance. So all those patients, when we have a metabolic cause responsible for an abnormal electrical milieu, they may require temporary pacing. So when you do not have any reversible cause, when bradycardia happens as a part of a degenerative disorder, those patients, when symptomatic, are candidates for a permanent pacemaker. So second classification can be according to the cardiac chamber spaced. So one can have a single chamber pacemaker, meaning thereby we are putting a lead in only one of the chambers. Commonly it is put in ventricular chamber because that is essential in most patients with bradycardia to ensure a ventricular contraction. So commonest is a single chamber pacemaker is a ventricular based pacing. Very few patients with sick sinus syndrome will have atrial single chamber pacemaker implanted, but it's almost always a rarity as of now. with dual chamber pacing in VO. So a single chamber pacemaker, thereafter we have a double chamber pacemaker. This is the commonest that is being implanted worldwide, wherein one lead is implanted in the right atrium and another lead is implanted in the right ventricle. Third is a triple chamber pacemaker, which is called a cardiac resynchronization therapy. Indication of CRT will come to know in brief in the later part of this talk when it is needed. But triple chamber pacemaker by and large is reserved for indications in patients with heart failure and not primarily for cardiac bradycardic indications. Third classification of pacemaker can be according to the surface based. I mean, where the electrode is implanted. So a conventional dual chamber or single chamber pacemakers or triple chamber pacemakers, they are all endocardial transvenous pacemaker, meaning thereby we introduce leads via the venous system inside the right side of the heart. And the leads are in contact with right atrium and right ventricle and in contact with the endocardial surface. There can be another group of pacemaker, which is called an epicardial pacemaker. Epicardial pacemaker, we have to put it surgically, either by thoracotomy or by access through the intercostal space or the subxiphoid space. And commonly after open heart surgery, surgeons tend to put up leads directly over the epicardial surface and then connect it to the external pacemaker. Most commonly, it is the temporary pacing via epicardial route which is being practiced. But in some patients where you do not get a good endocardial access, in rare instances, one can have epicardial leads also, permanent epicardial leads also placed and connected to the pacemaker, which is conventionally located below the skin in the pectoral region. So one can have, commonest indication is temporary epicardial, but yes, permanent epicardial pacemaker also is one of the option in patients where endocardial implantation is having some issues. So this is just to show how a temporary external pacemaker device looks. So this is a device here, and this is connected with the cable, and that cable is having two port connecting with a pacemaker electrode, which goes via the venous system inside the heart. So this is how a temporary pacemaker would look. And here you can see 3 buttons, and these 3 buttons ultimately we have to program from outside. And what we program will briefly discuss. So this is how a temporary external pacemaker device will look, and this remains outside the body. And once the patient recovers his own electrical activity, the temporary lead is removed from the body and disconnected from this device. So this is temporary external pacemaker. And this is how a permanent implantable pacemaker device looks. One can see how small it is compared to the external pacemaker. So this is an external pacemaker, and you can see this is an internal implanted permanent pacemaker. And we can see there are 2 ports for a dual chamber pacemaker. One is for the atrial channel, another is for the ventricular channel. And this is how these are the 2 leads which are traveling across the venous system inside the heart. So how do we implant it? So the vascular access for pacemaker implantation is via the veins predominantly. That is, as is very much evident that one cannot put anything through arterial route. So a temporary transvenous pacemaker lead travels via the femoral vein. There can be access for a temporary pacemaker via internal jugular vein also is possible. Commonly for permanent pacemaker access, we use axillary vein. Subclavian vein is not commonly being used nowadays. And coronary sinus, if we recall the venous system of the heart, venous drainage of the heart, via its tributaries, it drains coronary sinus inside the right atrium. So whenever we want to pace the left ventricle, we can pace by passing a lead across the coronary sinus and into one of its tributaries which overlie the posterolateral part of the heart, and one can stimulate the left ventricle. So if you see here this cartoon, you can see a small opening here. This small opening here in the right atrium is a coronary sinus. So you can see that here, this is typically a double chamber pacemaker device where we can see one of the lead is in the right atrium and another lead is in the right ventricle. A third lead can travel through the coronary sinus from this opening, and from this coronary sinus, a third lead travels into one of the tributaries of the vein, and then it stimulates the heart by providing impulse to the epicardial surface of the heart. So that is how even a triple chamber pacemaker would have an access to stimulate the ventricle. So both dual chamber, the dual chamber devices will have endocardial activation, and the lead put through the coronary sinus into the venous tributary will have epicardial stimulation of the left ventricle. So this is how the leads travel. So one of the ways how we localize the axillary vein is that in the fluoroscopy, we try to look for the infraclavicular region and look for the first rib. And we see to it that we don't puncture after taking a venogram. When we see the subclavian vein, the axillary vein becomes subclavian at the medial border of the first rib. So we try to puncture the axillary vein that is on the outer border of the first rib. And that's how we can prevent development of pneumothorax, because the lung apex is very near to this. In most instances, it's a norm, and that has remarkably reduced the incidence of pneumothorax because of venous puncture. So it's our default strategy to go via the axillary vein for permanent pacemaker implants. One can go via cephalic vein by dissecting it out and put in leads through the cephalic vein as well. But I think with the safety of extrathoracic puncture, axillary vein access has become a default for all permanent pacemaker implantations. So these leads, they travel across the venous system inside the heart. In the right atrium, the lead lodges into the right atrial appendage, and in the right ventricle, because the right ventricle is a trabeculated structure, a passive fixation lead can easily get fixed up into one of the trabeculae of the heart, or an active fixation lead can also be put up inside the ventricle. And with these two modes of fixation of the leads remain stable inside in contact with the endocardial surface. And the ports are connected to the device, and the device is fixed in the infraclavicular region over the pectoral muscle. And the wound thereafter is closed in the layers. So this is how a double chamber pacemaker looks, and this is showing a triple chamber or a CRT. We can see the first lead is in the right atrium, second lead is in the right ventricle, and third lead travels via the coronary sinus into one of the tributaries in the heart, and it can pace the left ventricle. So this is how a CRT would have leads implanted. So what parameters we look for optimum pacing? We look for a threshold. That means what is the minimum strength needed to stimulate the heart, and typically it should be less than 1 volt. Second, we look for impedance, that is resistance to flow of the current, which is usually between 400 and 1200 ohms. And third, we look for is sensitivity. That means what magnitude of electrical activity the lead is able to sense. So typically it should be more than 5 millivolt for ventricle and more than 0.5 millivolt for atrium. What parameters we program? We program the output, meaning thereby at what voltage the electrical impulse should be given to the myocardium, and it should be at least 2 times the threshold. We program the sensitivity, we program the lower and upper rate. As we discussed earlier, it is between 60 and 130 bits per minute, and we program the AV delay. And additionally, we observe on every follow-up what is the battery voltage and what is the battery life and what is the battery impedance, because as the device ages, meaning thereby after implant, depending on the consumption, the battery is definitely going to decline. Most pacemakers last for 10 to 12 years. And as time progresses, battery voltage goes down and the battery impedance starts rising. All devices almost always have that inbuilt function where they allow a warning. So a routine checkup, almost always one knows that yes, battery is going to deplete, and it's like a reserve phenomena. Whenever the warning turns up, it is called an elective replacement indicator. So whenever we check the pacemaker, that indicator turns on, and that means that once that indicator is on, we should be replacing the device within next 3 months. Patients who are lost on follow-up, who don't get the device checked at all, they at times come with loss of pacing. But all those patients who are on regular follow-up, which is advocated almost once every year, in all those patients, it is possible to find out when the battery is getting depleted and when it needs to be replaced. So it's a pretty safe way of managing patients on follow-up. So going into little detail of types of permanent pacemaker, the single chamber pacemaker, if it is ventricular based, it is called VVI. If it is atrial based, it is called AAI. Double chamber pacemaker is called triple D, and a triple chamber pacemaker is called a CRT. So what does those three letters mean? Like when we say VVI, AAI, triple D, what does it mean? So briefly, the first letter means the chamber paced, meaning thereby if I say VVI, that means the first letter is V, that means ventricle is being paced. If I say AAI, that means it is atrium being paced. If the letter is triple D, the first letter is D, that means both atria and ventricle can be paced. So first letter indicates what chamber is being paced. Second letter is what chamber is being sensed. So if we say VVI, the second letter is V, means it is sensing the ventricle. If I say triple D, second letter is D, that means it is sensing from both the chambers. Third letter is denoting the response to sensing. So if I say triple D, that means it can have dual response. If it senses that the native event is there, it will remain inhibited. And if the native event is not there, it will stimulate. So this is called response to sensing. And fourth is a function called rate modulation. So if I say VVIR, that means it's a ventricular based pacemaker with rate modulation possible. If I call triple DR, it is called a double chamber pacemaker with a rate modulation possible. So this is in brief how the pacemaker modes are denoted. So for rate modulation, the devices are equipped with certain functionalities which is inbuilt in its system. There are accelerometer, there are sensors for activity, there are sensors for minute ventilation, there are sensors which look into QT intervals, and of course the body temperature. Based on changes into these parameters, the sensors are likely to guide the device to increase the heart rate so that the patient can have a rate responsiveness to his physical activity. So this is how typically if we say that a patient is having a lower rate programmed at 60, it will keep on giving impulse at the rate of 60. If it is AI, it will give impulse into the atrium, and one can see that there is a spike followed by a P wave and then the QRS. If it is dual chamber, this is how it will show that it will pace in the, like here it shows that the event is happening because of pacing in the atrium, but ventricular event is being sensed, so it does not pace into the ventricle. So one can have a triple D function like this, that it paces in the atrium but senses in the ventricle. And this is another example where you have atrial activity but no ventricular activity. In that case, it senses the atrial activity and gives a pacing only in the ventricular channel. So this is how a triple D pacemaker would work. Why is rate modulation important in patients who receive a pacemaker? We know that whenever the patient exercises, the stroke volume reserves account for only about 50% of increase in the cardiac output. However, the heart rate reserves account for almost 300% increase in the cardiac output. And therefore, heart rate response is very vital to provide better hemodynamics and quality of life for the patients. And therefore, there are certain groups of patients where rate responsive pacemakers are important, especially those who have chronotropic incompetence, elderly patients, those who have LV dysfunction, sedentary patients, younger patients, and women. In all these patients, rate responsive pacemakers are supposed to be better. Brief about cardiac resynchronization therapy or a triple chamber pacemaker. In which group of patients we recommend it? We have seen earlier that in these patients, we have 3 leads implanted. One is in right atrium, one is in right ventricle, and one is pacing the left ventricle via the tributary of the coronary sinus. So the 2 RA and RV leads pace endocardially, and the LV lead paces the epicardially. Now, in which group of patients you need it? Typically, all patients who are receiving the CRT will have a left bundle branch block. And it's a must whenever a patient gets a triple chamber pacemaker. No patient with a narrow QRS will receive a CRT. This is the first and foremost specification that should be made with, that patients must have LBVP. Second thing is they should have a low ejection fraction that is less than 35%. They should be in NYHA class 2 or 3 on optimized medical therapy. Their QRS duration should be broad, more than 140 milliseconds. Their LVs should be dilated, but not extremely dilated. Whenever the LVs are extremely dilated, they lose the benefit of CRT. And one does not recommend a CRT kind of devices for patients who have comorbidities which limits that life expectancy beyond 6 months. So we have to see to it that the patients are not very sick and they have a reasonable life expectancy even after a device implantation. So why do they need it? Basically because the left bundle branch block, whenever it happens, what happens is the impulse travels via AV input down to the right through conduction system, but impulse does not, because of left bundle branch block, the left ventricle gets delayed activation, and therefore synchronous contraction between the septum and the left ventricular lateral wall does not happen. And therefore, this dysynchronous contraction tends to cause electrical dyssynchrony and mechanical dyssynchrony, which tends to worsen the patient's cardiac output. So in all those patients who have LVVB, low ejection fraction, and electromechanical dyssynchrony, CRT device with the help of 3 leads implanted in this fashion tries to improve or tries to correct this dyssynchrony. And it has been shown in clinical trials to improve ejection fraction, quality of life, and in some patients even having a mortality benefit. Going to, in brief, the advances in pacing therapy. So this is all about basic pacemaker details that all of us should know. Going in brief about the advances in the pacing therapy. First is MRI compatibility. MRI compatibility is now there, at least in Indian market, for almost now a decade. And most devices are now MRI compatible, which are implanted fresh in last 1 decade. We still need to be sure about device specifications. Some devices may be compatible with 1.5 Tesla MRI, but most have now converted to a 3 Tesla MRI compatibility. Second is about conduction system pacing. Third about leadless pacemaker. Fourth about remote monitoring, and fifth about prevention of infection in implanted cardiac devices. We'll briefly touch upon these points. MRI compatibility, I think I have already discussed. Going to conduction system pacing. What is conduction system pacing? So what, as I had detailed in the earlier part of the talk, that whatever leads we are putting, they are directly in contact with the myocardium. We are not pacing directly any of the fascicles or the conduction system. And therefore, whatever electrical impulse passes, it is given through myocardium. So it is being explored that can we directly pace this conduction system so that one can have a better electrical synchrony between the ventricles. So what we do is that the impulse is in the right atrium, it's not a problem. You put the lead in the conventional position into the myocardium directly. There is no need to be in contact with SA node. But what the lead is being put in the right ventricle, you try to put the lead directly either in the region of His bundle. So directly activate the His bundle, or you put the lead in contact with the left bundle of the heart. So directly, if you put it this way, it is likely to have a faster and a better synchrony as far as the intraventricular activation of the heart is concerned. And that translates into better outcome because electrochemical dyssynchrony is corrected to a great extent, and the cardiac output is supposed to be better in such kind of situation compared to pure myocardial stimulation in CRT or in other instances. So His bundle pacing or left bundle pacing is a new way of treating the patients with pacing indications. And commonly, the purpose is to synchronize biventricular electrical stimulation via the native conduction system. And it has got a role in patients who have an indication for a CRT or a triple chamber pacing devices. But with the increasing ease of implantation and technology evolving, it is likely that many patients with even bradycardia indication could receive in future conduction system pacing as a default. But I think that stage is little far away. We'll have to wait for technology to translate into that kind of practice scenario. Coming to leadless implantable pacemakers. So one can see here in the cartoon how small the device looks. This is a leadless implantable pacemaker. It is almost 93% reduction in the size compared to the conventional pacemaker. And MITRA VR and MITRA AV by the Medtronic company are the leaders in this leadless implantable pacemakers. So these are all indications for leadless pacemaker implantation. One would question that when you have a pacing technology for almost more than 2 decades now, where is the indication for a leadless pacemaker? The commonest indication is a patient on hemodialysis where you can't access one particular vein where you have AV fistula there. And if the fistula is failed and patient has got AV fistula on the opposite arm, definitely you can't have a venous access via the axillary veins or a subclavian vein to put up your leads. Difficult venous access because of prior implants, if the venous system is occluded, that is another indication. Third indication can be a patient who has got infected pacemaker pockets. If the patient has got infection on the device, no longer you can put the device from that particular side. And if you have exhausted both sides, there are going to be some patients who can have even bilateral pocket infected. And in all those patients, one may require lead to be put transvenous with help without lead going through the subclavian or axillary veins. So these are the two commonest scenarios where one advises a leadless pacemaker. In most other instances, it may not be required, but this chart, this figure summarizes most of the indications of a leadless pacemaker, wherein we have single surviving fistula, patients who are having bilateral mastectomy, patients on radiation therapy on the chest, lead-induced severe TR, those patients who are at a high risk for pneumothorax, bullous lungs, or emphysema. And patients who are at a high risk of bleeding, patients are already on oral anticoagulants and DAPT, where it is not possible to stop it for the procedure. So these are varied indications where a leadless pacemaker can be indicated, but I think commonest are patients on hemodialysis, difficult venous access, and prior pacemaker pocket infection. Except these two indications, other indications are relatively rare. And why it is important to know, because any technology which evolves, it tries to find out its space, and we as a clinician must know where to recommend it and where we can avoid it, because the cost implications are high, and there are going to be flip side of a given technology as well. Because a leadless pacemaker, let us say once the battery depletes, you don't have option to remove that device once it has been implanted inside the heart. So one has to go for a new implant, and that means you are going to put up another small pacemaker via similar transvenous access inside the heart. It is not possible to replace the device. So this is a brief video of how the leadless pacemaker goes inside the heart, and one can see by the femoral vein, the system travels inside the heart, and a device is deployed into the right ventricular apex, and after deployment, the system comes back. So this is practically a leadless one. The lead remains implanted into the right ventricle, and because the right ventricle is a trabeculated muscular structure, stability is not an issue, and it remains inside. So now we have a dual chamber AV synchrony possible with the leadless pacemaker also. It is called the MITRA AV transcatheter pacing system. It is not possible to pace the atrium because we know that this device is in the ventricle, so it cannot pace the atria, but it can sense the atria. It can sense far field electrical atrial activity and pace the ventricle as per the programming. So it is possible to have a dual chamber kind of functioning without atrial pacing with leadless pacemakers nowadays. So this is one such example of a patient who has got multiple devices inside. You have a MITRA clip here in the middle. What does MITRA clip do? MITRA clip tends to clip the mitral leaflets, and where it is indicated in patients who have severe mitral regurgitation. MITRA clip done percutaneously can reduce the mitral regurgitation. The upper part here, one can see that there is a left atrial appendage occlusion. This is for preventing left atrial appendage clot formation inside in patients who have atrial fibrillation. And one can see there is a leadless pacemaker inside the heart. And one can see already the clips here, which indicate that patient has already undergone bypass in the past. So this is how the technology is evolved, and for varied indication, the patient can receive varied mode of therapy. So as we had discussed earlier, that leadless pacemakers cannot be explanted. So this is one such example showing X-ray image where the after expiry of the battery, the patient is receiving a second leadless pacemaker. So coming to in brief about remote monitoring of implanted cardiac devices. So all those devices, they can talk to the outside devices via the Bluetooth connectivity. And that's why the technology is evolved to provide remote monitoring. how the devices function and what kind of electrical activities they are generating. All those things can be recorded. There is a smart technology, MyCare Link Heart app, which is proposed by Medtronic. All companies have it in their own way. Medtronic, St. Jude Medical, Biotronic, as well as the Boston Scientific. So wherein you have a smart sync device manager, and there is a MyCare Link Heart mobile app, which is there on patient's smartphone, and there is a CareLink network, which integrates the information gathered between the patient's device and the medical professional who is providing the monitoring services. Lastly, coming to the infection of implanted cardiac devices. Whatever the implant always carries some risk of infection, and it is said that almost 1 to 4% of implanted cardiac devices carry the risk of infection. And therefore, prevention is of utmost importance. And despite all preventions, I think those numbers cannot go away, and it's never zero, the risk of developing infection. So this is some examples how the pacemaker pocket infections look. Commonly, it is in early part of pacemaker implant if the patient gets infection, but it can be as late as even 1 year or 2 year also. One can have skin showing adherence, one can have perforation, one can have overt erosion, and one can have even frank pus formation also. So this carries a lot of morbidity, and 1 year mortality of such patients are going to be high. There is always going to be some risk of endocarditis as well, and therefore every effort should go to prevent infection as far as the implant procedure is concerned. Commonly, the pre-operative antibiotics and post-operative for 48 hours minimum injectable suffices, but I don't think that it is completely preventing the risk of infection. And therefore, the technologies evolved to now provide an absorbable antibacterial envelope with the device called the Tire X. This Tire X envelope, you put the device inside, and with this envelope, we implant in the pacemaker pocket. So what does it do? It locally delivers minocycline and rifampicin for a period of almost 7 days. And it's a multifilament which is kneaded and gets fully absorbed in approximately 9 weeks time. So nothing remains inside, and that is supposed to show significant reduction in the risk of infection. In one of the studies published in New England Journal of Medicine in 2019, it had shown that there is 40% reduction of major pacemaker-related infections. There is 61% reduction in the pocket infections, and there is no increased risk of complication with the use of this system over a period of a year. So I think this is in brief about what advancements we have seen in various issues related to pacemaker therapy. And I think with this, I'll end my talk here, and we'll be open to questions. Thank you.
Thank you, Dr. Chirag, for a wonderful talk. Although a little technical for me as a pediatrician to understand, but quite informative.
Yes.
We are open for discussion now. Any comments, questions? You may stop the screen sharing.
Sure. Yeah.
Any questions or comments from physicians are welcome.
Do you recommend infective endocarditis prophylaxis for any procedure, including dental?
Per se, it is advisable that if the patient who has a device inside, one should recommend, and that definitely will prevent lead-related infections. In general, patients who undergo dental treatment and has a device inside, the risk is not that great. The risk is higher if you have associated valvular problems. But by default, yes, one should recommend antibiotic prophylaxis before any operative procedure, especially dental.
There is a question in the chat box, but it seems to be incomplete. Like, what is life if leadless pacemaker? Then one doctor said, I asked this question.
Yeah, so leadless pacemakers also have a life of about almost 10 to 12 years. But after that, one needs to put up another one. We can't remove it. Like the conventional pacemakers, we can remove the battery, put up another, and connect with the leads which are already implanted. Here we have to go through the same procedure again and put it transvenous, a leadless pacing. So I think some of the common questions that we face is one is MRI. Can the patient undergo MRI? So if there are no questions, I would like to share some more information. So patients who have a pacemaker, if the pacemaker is MRI compatible, yes, they can undergo MRI nowadays. That pacemaker is supposed to be programmed to a non-sensing mode, and pacemaker circuitry thereafter remains protected from the heavy magnetic field, and most patients will be able to go through MRI. What you should recommend it that they should visit the hospital, they should contact the pacemaker representative who can remain present at the MRI center, that the device is programmed in a way which is protective for MRI, and once the MRI is done, that function can be switched off, and then patient can go ahead with a normal routine. So it is possible to do MRI. That is one. Second is yeah. So most patients with a device implanted can pass through the security gates which have sensors. It's not a problem. All across the airports or over the malls and everywhere, it's safe to go through the security gates. It's not a problem. For the security checkup, you can just ask the security person, and announce that you have a device, so that they should not be holding the wand continuously over the device. Because if they hold it continuously, pacemaker can get inhibited. So if they just use it as a part of screening that you have a metal device, it's not a problem. It is not going to harm, and most patients can travel safely without any additional problems. Second question commonly comes is what happens during surgery. Like most feel that you have once a pacemaker in surgery can be an issue. What is recommended is again, if your surgical site is more than 1 feet away from the left pectoral or right pectoral region, it's not a problem. One can go ahead with surgery as a routine, and the pacemaker programming is not required in most instances if the surgeon uses a bipolar cautery. If surgeon uses a unipolar cautery, then there are chances that there can be electrical interference with the pacemaker circuitry, and pacemaker can get inhibited. Therefore, it is recommended that it should have a bipolar bipolar cautery used for surgery. In patients who have, let us say, surgery in the upper limb or upper half of the body, yes, it is recommended that pacemaker should be programmed to non-sensing mode. So if it is a VVI pacemaker, we program it to VOO mode. If it is a DDD pacemaker, it is DOO mode. What does it mean? Simply that pacemaker is blind to what is happening outside. Without external interference, it will keep on giving impulse to the heart. It will not become inhibited. So that gives safety during the procedure. And once you finish with the surgery, you again program back to the regular triple D mode or a VVI mode, and it will function as normal before. So I think these are pretty standard things being done, but yes, they need to be advised that yes, with as per the anesthetist advice, one needs to program it appropriately before and after surgery.
So who does the programming? I mean,
programming like all cardiologists can do. We do it on our own in most instances. But yes, pacemaker company representative also can do, but we are all trained to do it on our own as well. We can also do it.
So you connect through a mobile, or there is some?
There is a programmer there which connects with the device via Bluetooth, and we can program device parameters and functionalities. We can access the data what pacemaker has derived also. Whether it has recorded any arrhythmia, whether they have recorded ventricular ectopy, how much the pacing has happened, whether it is sensing any atrial fibrillation. So all those details can be obtained via this programming.
So this can be done remotely also?
This can be done remotely provided the device supports that function. Not all patients can have remote sensing available. Remote sensing is very common in West, not very common in India, because it adds to the cost of about 1 to 1.5 lakhs. So, and again, access to care is not a big problem in India compared to West, and therefore remote monitoring is not very much popular here. But yes, in West it is very popular. And now with the experience in Corona, increasing number of patients, whenever possible, they do opt for remote monitoring of the device as well.
That's great. Dr.
Chirag bhai, Dr.
Yeah.
Emanson,
Yeah.
two comments. One is that
Yeah.
intraclavicular pacemaker in our ages, when
Yeah.
patient used to lose weight
Yeah.
and lose fat,
Yeah.
I have put two pacemakers back because they had popped out from the subcutaneous tissue.
Yes.
And second issue is after death of the person, I had
Yes.
two phone calls in
Yes.
10 years. So what to
Yes.
do of the pacemaker? In one
Right.
case, I asked the cardiologist to remove it and showing
Yeah.
as a demonstration to medical students.
Right.
So have you faced such an issue?
Yeah, I mean, coming to first question, that erosion of the device, most commonly, like in our group of patients, subcutaneous tissues may be really less, fat tissue may be less. So device can get erosion, that's a possibility. But in general, what we have seen is it is more of a technical problem to the as a first thing. Because in very lean thin patients, if your pocket is adequate sized, most often erosions doesn't happen. Uh, uh, there is almost always a reasonable subcutaneous tissue which will prevent it. But yes, in malnourished patients, very lean thin cachexic patients, device can erode through. There is always a possibility. But if your pocket is small for the device, that device is likely to be eroded irrespective of extent of subcutaneous tissue. So what I'm trying to tell you is there are both factors, a technical factor as well as patient related factors. Both can be there. So on our part, we should be sure that the device pocket is adequately sized. That is one. And we ask the patients not to sleep on their stomach for a long, I mean, just to prevent excess weight on the device part. So it is possible that device erosions can happen in cachexic patients. That is possible. It's a real possibility. Coming to second question, because the device contains a battery, as per the customs of Hindu funerals, the battery can get exploded. So that is one thing due to which we ask that the battery should be removed. But where the burying is a uh, tradition, where it is not compulsory to remove the device, so one can allow that process without removing the device also. So this is what the standard advice to the patients do. And any surgeon can remove that device because nothing else is to be done. Just a small incision and cut it, remove the device and cut the leads. That's all. And just suture the wound. Don't leave it open. It is traumatic for the attendants to witness that, basically.
Oh, I have done that twice. That's right.
Yeah. Correct. Right.
There was a question from Kiran Bhai about what about CT compatibility.
CT absolutely allowed, no problems. CT can be done, ultrasound can be done, everything can be done. It doesn't interfere.
Okay, it seems there are not many questions now. So thank you,
Right.
Dr. Chirag.
Right.
It was
Thank
a
you, sir.
wonderful presentation and a good interaction also.
Yeah. Thank
Again,
you,
I mean, we'll invite you again and again and again.
Sure. I'll be happy to come, definitely.
Thank you.
Thank you,
so
sir.
much.
Thank you,
All.
everybody.
We end the session here. Next Saturday, we'll have Dr. Aisa to talk about some dental issues. She's an endodontist. So next Saturday, we'll have that as a speaker. So
Right.
thank you all. We end the session here.